Welcome to today's MESUD Learning Community Echo, Adolescent Medicine, How SUD Fits. Today we'll be hearing from Ashley Moore on relationship violence. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health, Leadership, and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. Recording and live stream transmission of this webinar without consent is not permitted. And now I'd like to give a quick introduction to our speaker today. Ashley Moore is a licensed clinical professional counselor in the state of Maine. She's centered her career on working with adolescents and young adults in both clinical and academic settings. Ashley's clinical work is focused on treating complex presentations, including individuals with chronic medical conditions, eating disorders, and emerging personality dysfunction. Ashley presently works as a BHI clinician with Maine Health at the South Portland Pediatrics location. And with that, I will hand it off to Ashley for our presentation. Thank you all for being here today.
Thanks very much, Bethany. Can everybody hear me okay? Head nods, great. Okay. So today I'm going to be presenting on relationship violence in adolescent and emerging adult relationships. Obviously, there are some differences between those two populations, but for our purposes today, we're going to be looking at some of the primary risk factors of both the perpetration and the victimization of individuals who are in dating relationships in both their teen, adolescent years and the emerging adulthood years, which technically begin at the age of 18 and extend to, depending on who you ask, 26 to 28. Couple of quick disclaimers before we jump in today. The first one is that just in case everybody is, just to be aware, we're going to be discussing some topics that can be painful or triggering, including relationship violence and violence toward minors. So please keep that in mind, and please take care of yourselves as you need to throughout the presentation. In addition, it's really important to note, and we'll talk a little bit more about this as we go through, that when we look at the data around violence in dating relationships in adolescents and emerging adults, what the data shows us is concerning in the fact that the violence that we see actually tends to be mutual violence. So if we are working with a patient or a client in our office, and we are hearing red flags around violence in the relationship or abusive dynamics, we need to sort of be aware that we might be sitting with someone who is potentially both a victim and a perpetrator. And so we need to kind of take that framework to be really effective in our intervention. Bethany, do you just want me to tell you when to go to the next slide? Sure. Okay. Yeah. Next slide, please. Okay. So I know I'm preaching to the choir here. Just a quick forward about the adolescent and the young adult brain, because it really is a fascinating organ at that time. So it's important to remember that there are biological processes that are occurring in our adolescent and young adult years that actually prime us for an increased risk of relational violence. And I'm going to use, just so you all know, I'm going to use the terms dating violence, relational violence, intimate partner violence, kind of interchangeably referring to the same thing. In the adolescent and young adult brain, we see that the limbic system is developing at a much faster rate than the prefrontal cortex. So again, limbic system being the part of our brain that really is about risk, reward, and sort of sensation seeking. And that the prefrontal cortex is the part of our brain that's in charge of executive function. So things like planning, judgment, organization, behavioral inhibition. So if we have a limbic system that's really developing rapidly and a prefrontal cortex that's trailing behind a little bit, we're going to see increased risk for both risky behaviors and high reward seeking behaviors. What's really interesting is that the combination of factors, the limbic system kind of leading the charge developmentally and the PFC sort of dragging behind, also means that we are particularly reactive to emotional experiences. And in our teen and our adolescent and emerging adult years, we're particularly sensitive to negative affectivity and experiences that create that negative affectivity, such as social rejection. So relationships are high risk, high reward during these years. Also, again, with that PFC sort of trailing a little bit behind, there's less capacity for judgment, less capacity for behavioral inhibition. And we're going to see throughout the course of this presentation how that puts us at increased risk for violence. Just to speak to relationships kind of generally in adolescence and young adulthood, this is the time of life in which younger folks are really, really leaning on on their peers. They are learning how to form safe and healthy relationships across the board, right? Which is why we know that the peers really become kind of the center focus of this age group. Bethany, if you could go to the next slide. Thank you. Um, so we have this time of life where people are really getting the opportunity to practice adult relational dynamics. And if we've got a good group of peers, then this can be reinforcing healthy behaviors. It can help us to develop and practice social skills like conflict resolution, effective communication, resisting peer pressure. It can be a really fruitful sort of space to be practicing the skills. But alternatively, these same relationships also have the power to encourage more negative or concerning behaviors, such as high social comparison, resulting in lower self-esteem if they don't feel like they measure up to their peers, or being encouraged by their peer group to engage in negative behaviors via peer pressure. So, kind of side note here, if we think about the importance of relationship, this really highlights for us as providers in healthcare that we need to be asking our patients and our clients about their peers, about their friends and their dating partner, or else we might be missing really crucial risk factors and risky behaviors. Something really interesting to me was we are seeing data that currently suggests that dating and sexual activity in adolescents are actually decreasing in the recent years. We can come back to this in the Q&A. I suspect there's a myriad of factors that play into this, particularly the fact that this generation is now digital native. So the way that they learn to connect with others looks a little bit different. But about 2/3 of 13 to 17-year-olds have never been in a romantic relationship. And then also we're seeing decreased sexual activity from 54% of high schoolers in 1990 reporting that they engage in sexual activity to only 38% in 20. So all of this to say that relationships in general, really, really important during this time. They come with lots of great opportunities, but also high risks. Bethany, next slide. Thank you. So many of you might recognize this graphic. This is one of the many versions of the Duluth model of power and control. So we really use this type of a graphic to help people understand the types of violence, abuse, and control that occur in the context of relationships and why they happen, right? We look at like different areas that a perpetrator of violence might be looking to control, to more sort of ubiquitously control the person that they're in a relationship with. Good news is we've also developed models on the other side of things that look at empowerment, right? And how to teach adolescents, young adults, people in general, how to feel empowered in their relationships, how to recognize sign of controlling dynamics, and how to sort of buffer against that. But as a general rule of thumb, when we think about the type of relationships or the type of violence that happens in dating relationships, we're thinking about three primary areas: relational violence. And this kind of encompasses psychological violence as well. These are things like peer pressure, starting rumors, isolation or ostracizing out members, right? People that don't belong to your peer group, name calling. And these often kind of wrap themselves into that psychological or mental abuse that really is about trying to make someone feel small. There's, of course, physical abuse. This is concerning. This is anytime someone's laying hands on, causing physical harm towards somebody. And then there's sexual abuse. And we sometimes will sort of differentiate between categories. So there's sexual coercion, which is about being pressured into doing things or saying yes to sexual acts that you don't actually feel comfortable doing. And then also just sort of more blatant sexual assault, so non-consensual assaults with a dating partner or a sexual partner. Could we go to the next slide, Bethany? I'm going to kind of talk a little bit about the sort of a couple different areas when it comes to violence in young adult and adolescent relationships. We're going to look a little bit at some of the trends that we're seeing in the current day. And as I talk about trends, you'll note that I'm really referencing one major survey, and some of you may be familiar with this. It's called the Strive survey, and it's a survey on teen relationships and intimate violence. It really was the first comprehensive household survey that they did on teen relationships and the violence that occurs within them. This was done by Taylor Mumford and Liu. It began in 2013. They started collecting data in 2013. It was a longitudinal study that ran all the way through 2020, and they collected 6 waves of data, so trying to get some trends over a good chunk of time. By the time all the data was in and we looked at the results, we're seeing a couple of things. One, nationally, we see higher rates of violence in teenage and young adult relationships here in the US than we originally predicted we would. However, if you break the data down and look at location specific, it evens out a little bit. So if we're looking at sort of the grand picture, we see higher rates that surprised us a little bit. But if you start to break that down into specific regions, it seems to sort of line up a little bit more with what we anticipated. Another really important sort of trend that this survey uncovered was that high overlap between victimization and perpetration. So approximately 84% of people, of teenagers and adolescents that were reporting being victimized in the context of their dating relationship also endorsed perpetrating violence against their partner. So the mutual dynamic there is really, really important. Interesting to know also, there are no reported differences in victimization rates between males and females. But what's really interesting is that females are actually reporting that they perpetrate psychological abuse and physical abuse more frequently than males. And we can come back to this in the question and answer section. I suspect that's surprising for many of us. But what we really have to remember here is that this is about willingness to report. And that may also play into this. Could we go to the next slide, Bethany? Thank you very much. And I apologize. I know I'm moving at a really rapid rate. I'm trying to really protect our time and keep us to that 20-minute limit. But I'm happy to go back over anything at the end. So I also wanted to talk about some risk factors, right? So if we know that this is a time of development where we're seeing increased risk for violence in relationships, then we really, and we know that during this time, it's also a time where people are really being heavily impacted by negative social dynamics. We probably want to have an understanding as healthcare providers of the types of things that might put our patients at particular risk for experiencing these types of dynamics. So a couple risk factors that really stand out in the data, and there's a swath of them. So I really chose the one that seemed to be sort of the most relevant to us in our work, is individual characteristics. This is specifically the data that seems to emerge is negative mental health. So if we're working with a patient who is struggling with their mental health, that's a risk factor for them experiencing violence. It's when we look at the data, particularly a risk factor for females. It doesn't mean that it's not a risk factor for males, but just that we need to be a little bit more worried about our female patients who are coming in with a negative mental health history or present experience. The type of relationship that they have with their parents, if they have a negative relationship with their parents that's wrought with conflict, that's a risk factor for experiencing violence in the dating relationship. If they have previous exposure to any violence, and this was really fascinating to me, right? It's not just previous exposure to household violence, previous exposure to dating violence. Exposure to any violence puts somebody at increased risk. Unhealthy relationship dynamics in their relationships. So things like control dynamics, dynamics that are sort of wrought with putting one another down. This is something I see a lot in the work that I do with adolescents and young adults. They seem to bond with their peers through banter, right? And through teasing with one another. And when that's done with sort of a basic understanding that there isn't harm intended there, that doesn't necessarily negatively impact people. But the key is that there's sort of that mutual consent and understanding. And for a lot of people, there just isn't. So they may actually be experiencing that banter as attack or as like isolation or ostracizing from the group. This was really interesting to me because this seems to stay steady between both adolescent, young adult, and adult relationships. A risk factor for experiencing violence in the context of a relationship is conflict, specifically over finances. So this will come back around because this gives us a really good idea about how we might do some intervention with both. And then finally, this is really important. We know that our patients that are a part of the LGBTQ community are at increased risk for violence, period, frankly, but that extends to the context of their dating relationship. It's really important to note, and thank you very much. Yeah, you can stay right there, Bethany. It's really important to note just before we move on, that studies often focus on the individual risk factors, right? So the risk factors I just named are all about the person themselves or the dynamic between two people. But it's also key to note that the risk of violence in relationship rises above and beyond those factors. For example, if a person resides within an area or within a culture that really sort of um, aligns with specific gender roles, we tend to see higher rates of violence against women more broadly in all relationships, including adolescent relationships. So really key to note that while I'm sort of presenting individual factors, that there's a larger systemic sort of system at play here. So now we know about the trends, we know about the risk factors. Let's look at what's really important to us, which is what happens? What are the negative impacts of somebody being in a relationship in which there is violence? One, we see increased mental health concerns, right? So this is particularly concerning given that negative mental health is a risk factor for violence, and then the experience of violence then doubles down and presents increased risk for mental health. We specifically see increased symptoms of anxiety, depression, and poor body image very frequently for women. I looked at one study that looked at how unfortunately, if a female adolescent or young adult is in a relationship in which there is violence, they are more likely to develop an eating disorder. They are also more likely to utilize diet pills, which is concerning. We also see decreased school performance, increased risk for truancy. We see increased risk of pregnancy and STIs. And this is particularly concerning, of course, to us as healthcare providers, but also because if a person becomes pregnant in the context of a relationship, the risk for control and violence also increases. We see that another negative impact of relational violence is that people will struggle to have and establish healthy relational dynamics down the line. So those unhealthy relationships and their dynamics will follow them into future relationships. And then, particularly important to our conversation today, we also see an increased risk for substance use, which I'll discuss on the next slide. Go ahead, Bethany. Thank you so much. So substance use and relational violence, the relationship between substance use and the risk around violence in relationships in the adolescent and emerging adult years is complex and it's bidirectional. So we know that substance use increases the likelihood of both victimization and of perpetration. We also know that other factors moderate the role of substance use, particularly the role that substance use plays in perpetration. So, for example, if there is heavy drinking, we know that that will increase the risk for perpetration of violence in the context of a relationship. We also know that if that person comes from an environment in which there is high social or family control, meaning that there is expectations that are enforced consistently in the family or social setting, that this actually goes down to almost zero. So if there is low social control, the drug use or the substance use increases the risk of violence. But if we implement social control, it almost totally negates the impact, which has a really substantial implication for family dynamics and the role that they can play in preventing relational violence. When it comes to like what are the substances we're really paying attention to here, the data kind of varies. It speaks broadly of drug use, but it seems that heavy alcohol use and hard drug use, specifically cocaine, LSD, ecstasy, and the misuse of prescription drugs, seem to be the most predictive of increased violence. Okay, next one. All right. So the reason that we're here entirely, right? How do we help? How do we engage in prevention as healthcare providers, whether we are their primary care provider, their behavioral health provider, or anywhere in between? We really want to look at two primary areas, right? Kind of bi-directional, multimodal prevention strategies. On the one hand, we want to we want to reduce the risk. On the other hand, we want to increase the protective factors. So when we think about how do we reduce risk, right? We can do things like if we are a primary care provider, providing education and options for contraception, right? Particularly around that role for decreasing pregnancy. We can be sharing resources that are both safe and informative. If anybody's interested, feel free to email me after the fact. One I listed here is loveisrespect.org, fantastic website, and it also comes with safeguards. So if somebody is on the website and a perpetrator is nearby, they can hit the space bar and it will completely clear out that browser and exit them from the website. So it's a really great resource. It also comes with a ton of information about what healthy relationships look like, what they don't, and how to get help if they suspect they're in an unhealthy relationship. We can be talking with them directly and openly about consent, which I'll talk about on the next slide. We can also be discussing and assessing their substance use patterns, understanding that this puts them at increased risk for both victimization and perpetration. When we think about how do we increase protective factors, we can help support them in connecting with behavioral health, particularly to build skills for managing conflict, regulating strong emotions, identifying coping strategies, right? If we know somebody has a background of trauma or an experience of violence, we might recommend behavioral health intervention. And then also recognizing that parents, even though peers become incredibly important during this time, parents are still the most important relationship that an adolescent has, as shown by that sort of modulating factor of social control, right? And that if we can be encouraging and empowering parents to remain active and engage in their teen's life, that's one of the best things that we can do to increase those buffers. Next slide. Consent. Some of us in the space might feel super comfortable talking about consent. As a behavioral health provider that works with young adult, this is a conversation I'm having on the daily. Some of us might feel less comfortable with it, and that's okay. But what we know about how to talk about consent to teens in a way that's effective is we have to be direct. We can't skirt around it. We can't use euphemism. We have to just ask the questions and give the information, as uncomfortable as that might be for us. We should be trying to talk with them, not at them. So one of the things that can often happen when we talk about consent is we ourselves are uncomfortable. So we just sort of give this quick lecture and hope that they got it. And what I know about teens is they don't got it. They really need to have a dynamic. They need to feel like they're being heard and understood and that they can ask questions. So open-ended questions and reflective listening. This is what I'm hearing you say in my own words are key here. Being sex positive, right? Not coming at the conversation of consent with shame, with disgust, but being like, hey, interest in sex is normal. It's healthy. Let's be informed. That is what is most important. Taking development into key is really important. We actually know that starting the conversation about consent young is necessary and useful, but it has to look a little bit different, such as focusing on body safety, body autonomy, and of course, appropriate anatomical terms. So thinking even before their adolescence about how do we have these conversations with them. And then finally, in emphasizing enthusiastic consent. I think this is where we often get things wrong, not necessarily as health providers, but just as people who talk about consent in general. We tell people you need to hear yes. And really what you need to hear is, excuse my language, hell yes, right? There needs to be an emphatic, enthusiastic yes, and anything short of that should be considered a no, right? Great graphic here. Consent is fries. When I worked in the young adult transition world and we would do sex ed with them, this is what we would use. It's talking about that consent is freely given, it is reversible, it is informed, it is enthusiastic, and it is specific.